Hello and welcome to the Lancet Voice. It's May 2025, I'm Gavin Cleaver, and together with my co-host Jessamy Bagenal, we're joined today by Dr. Hugh Alderwick from the Health Foundation. With the Labour government focusing quite heavily on health since coming to power here in the UK, there's a lot to discuss, from the imminent 10-year plan for the NHS to the recent decision to dismantle NHS England. In this chat, we really wanted to look into the challenges of balancing funding and reform, talk about the role of AI in healthcare, and the urgent need, of course, to improve access to social care. I hope you enjoy this conversation with Hugh Alderwick. Hugh Alderwick, thanks so much for joining us from the Health Foundation today. And we wanted to talk a little bit about Labour's record in government since coming to power on health. A lot of their political capital so far has kind of been spent on health generally. The budget in October was focused quite heavily around funding health, at least to a better degree than the outgoing Conservative government. But I wanted to ask kind of what stands out for you as the most meaningful intervention that Labour have done so far since coming to power in terms of health?
Well, it's quite a mixed bag so far. And really, we're still waiting for what's promised to be the most meaningful intervention. So there's a 10-year plan that government has promised they're going to produce on the NHS that's supposed to be published around springtime. You normally add a season when government says spring, so probably more like the summer. And really, that's going to set out their vision for how they want to reform the health service. They've talked about 3 big shifts, like shifting care out of hospital. But a lot of the detail is supposed to come later. And actually, the big story has been the narrative about problems in the health service so far. So they came in to power and really emphasized the problems, the depth of the crisis in the NHS. And fair enough, they came into power after 14 years of Conservative governments, and the NHS is in crisis. People are waiting too long for hospital treatment. They're waiting for general practice services. Public satisfaction is worst on record. So there is a crisis. But they started by really emphasizing the depth of these problems. They commissioned someone called Aradazi to set out this diagnosis of the issues in great detail. They've now got to shift to saying what they'll do about it, but we don't have a lot of the detail yet. But then alongside this, there's been this other plot, which was more unexpected, which is a few weeks ago, they announced they were going to scrap the big national body that runs the health service day to day called NHS England. That wasn't really part of what we expected the plan to be. The timing was, again, unexpected. So that's been almost the biggest thing for debate on the NHS, which is not what anybody expected. I think not what government had expected when they came into power. And that's going to shape what happens over the next few years, as well as these bigger ideas about reforming the health system. So you've got on one hand, some ideas about how you could improve the health service, and the 10-year plan is supposed to set out what they are. On the other, you've got some quite technical administrative changes about who makes decisions at the top of government on the NHS, how much a minister's involved. And that's going to take up a lot of time and energy. And that's really about structures and organograms, less about big ideas about how you improve the health service.
Hugh, just for our international audience, just give us a brief overview of how NHS England relates to the NHS and what the sort of budgetary numbers are around the amount that this organisation is doing or used to do and what it used to cover.
Yeah, so this is a organisation that got set up about 12 years ago, so under something called the Lancet reforms to the NHS. The background is there's big reforms to the NHS in 2012 by the coalition government. They did a bunch of things. They tried to enhance competition in the health service, but they also had this idea that you could put the day-to-day management of the NHS more at arm's reach from politicians. And that's not a new idea. Since the NHS was born, there's been this debate about what's the appropriate role of politicians in managing the health service. And then at the top of government, can you split sort of strategy for the health service and the day-to-day management? So these reforms and NHS England sort of took that debate to its conclusion, if you argue that you can try and split these things up. Basically, a quango body full of technocrats has been set up to take the funding that the health service is going to spend each year, allocate it to different areas, provide guidance, run big programs like screening, So it's essentially a body that's been set up to manage the health service day to day. So it manages a lot of funding, but it distributes a lot of it to the health service. And so what government has said is that they want to bring that back into the Department of Health. So they're scrapping this body, they're merging its functions back into the department, and they're also going to cut, they say, the number of staff working in the Department of Health and then it's in half. So that might be about 10,000 jobs. Gets even more complicated because this body called NHS England runs regional organisations that oversee the health service in different parts of England. So the government has to work out what it wants to do with those ones too. So the simple idea is this was supposed to take the politics out of managing the health service. In practice, that didn't happen. So there's some logic to bringing these two things closer together. But the job of bringing it back in is not a straightforward one. It's not just moving a few people around. It means redrawing boundaries about who does what. It will mean legislation, and that can always evolve to something that you didn't expect it to be as a parliamentarian. And it will mean lots of people that are responsible for managing big things in the health service will be reapplying for their jobs or losing their jobs, or working out what the new structure looks like and spending less time focusing on improving services.
Thanks, Hugh. I got lots of emails from people in the global health community asking whether we had shut down the NHS.
Yes. Because I had the same. Lots of my American friends. What on earth is happening?
I
It
know.
must
I
really
saw.
had this impact. Is this chainsaw to the NHS? No, don't worry. It still exists.
But there were actually some polls at the time, weren't there? I think something like 30% of people in the UK thought that Labour was trying to shut down the NHS as well.
This is the funny thing about it. Like, on the one hand, no patient. Well, not no patient. I'm a patient. I knew about it, but most patients are never going to have heard of NHS England. But the flip side is the work to abolish it, merge its functions into the department, or devolve them to some local body, or to set up something else a bit different, will take time and energy that those people could have spent on improving services for patients. So on the one hand, you think, well, look, this is just technocratic changes and we shouldn't worry about them. On the other, they will have quite big impacts. And the question is really, why now? You've got a health service that is in crisis. You've got people that are waiting too long for care, people in hospital corridors, not being able to be admitted to hospital, suffering harm. Is this the big issue you really want to focus on?
Yeah, and Hugh, I wanted to kind of just touch back on something that you were talking about, this 10-year plan that everybody's expecting. Just for people who don't kind of live and breathe the NHS, we've had 10-year plans before. What format do they normally take? Why does the NHS do them?
Good question. Yeah, the NHS has a long history of producing long-term plans. So in the 60s, for instance, we had a sort of long-term hospital plan for the NHS. Just over the last 25 years, we've had three big ones. New Labour had something called the NHS plan in 2000 that set out this vision for the health service. We had something called the long-term plan a few years ago. So we've got various versions of these, and they're supposed to set the long-term direction. Given that the challenges facing the NHS and other health systems are long-term, the idea is to get some consensus behind the direction for the health system. But also they're political tools. They're sometimes used to lever money out of the Treasury. Here's the direction we want to take for the NHS over the next decade, and here's the funding we need to do it. So there's a long history, and looking back at that history, you learn a few things. So one is that the context for the plans is almost more important than the content. So for example, when Labour were last in power and Blair was the Prime Minister, Brown was in the Treasury, there was a long-term plan that was produced, but there was also nearly 7% growth in NHS spending year on year, and that really enabled the NHS to improve. The ideas in the plan were important, but really the resources were the big driver of spending. Right now, there's far less resources likely to be invested in the health service, which will constrain what any plan can deliver. Another lesson is the plan's just a starting point. Often a lot of the detail comes later. So again, if you look back at the plan under Blair, a lot of the big reforms to the NHS over the decade that followed weren't mentioned in the plan, and they came later. This is sort of the starting point, but they're used for different reasons. This plan is probably going to be published around the same time as something called the Spending Review, which is a process in government where the Treasury will set out what each department will get over the next few years. So there'll be, here's the money and here's the plan. So it should really set the tone for what the NHS can do. But we've got the plan, but we've also got the political priorities, and we already know sort of what they are. So the government's already said their one big target on the NHS over the next 5 years is to reduce waiting times for routine hospital treatment. So whatever the plan says about shifting care out of hospital, preventing disease, we know that's their big priority. And we know achieving that's going to take substantial resources. There's a big target for 92% of patients to be seen within 18 weeks of being referred from their GP. Haven't hit that for a decade. Meeting it will take substantial resources. And even if you just focused on doing that, it'd be hard enough. So there's going to be what's written in the plan and what's the actual reality of what politicians are going to prioritise.
Talking about these plans, I wanted to ask as well, how different is the situation that 2024 Labour inherited from the situation that 1997 Labour inherited?
It's a really good question. It's actually similar. You think about in the 90s and now, Labour's inheriting an NHS with a waiting list problem. A big difference there is Labour also had an economy that was growing at that point and could invest. We don't have that now. We've got sluggish economic growth and we've got public services beyond the NHS that also require investment. Similar challenge in terms of addressing a waiting list crisis and improving the performance of the NHS. A big difference in the resources that are likely going to be available. But if you look back, Labour was successful over that period at reducing the waiting list. It shows what's possible when the NHS is given the resources and the staff, a big increase in staff working in the NHS in that period. It can deliver, it can get itself out of these crises, but it needs to be supported not just through good policy ideas, but also investment and a long-term objective to try and do something like reducing the waiting list. Chopping and changing makes it more difficult.
Yeah, I wanted to ask actually what your opinion was on kind of reform versus funding, because there's been a lot of talk. Keir Starmer said no funding without reform for the NHS when Labour first came to power. But a lot of what people talk about are the need for increased resources, beds, hospitals, scanners, all that sort of the IT, the very boring investments generally. Yeah, what are your thoughts on reform versus investment?
Yeah, I think it's a really good question. You clearly need both. You need to have an idea for how you want to improve the health service and some policies that align behind that idea. So, for instance, you might want to increase activity in hospitals and maybe you'll change the payment system to help that happen. That happened in the 2000s. You might think that collaboration is the only way that hospitals are going to get out of this mess they're in. So let's introduce some policies that reduces competition between hospitals, that tries to measure their performance collectively and shares waiting lists across a geographical area. So there's policy matters, ideas matter, but reform is way overplayed as the big driver of improvement in the health service, and investment is way underplayed. Again, we look back at the 2000s. There was big ideas for how you improve the health service, some reforms, targets and terror is what's often called. We had clear targets, performance management to achieve them. That clearly helped make use of more investment. But the story of how the NHS improved in the 2000s doesn't really make sense without the investment. So we can look back and learn the wrong lessons. We can look back and think the payment system changed, the targets changed, the organisation and management changed. Yes, those things did happen and they likely helped. But the big driver seems to have been the increase in resources during that period.
One political commentator said recently the kind of dangers of succumbing to the reform fairy, the idea that we can wave the fairy's magic wand of reform and all of our problems will be fixed. But I think you're exactly right. Investment is massively underplayed in this issue, isn't it? And so I wanted to ask what you thought of the spending increases that were given in the October budget for the NHS.
So it brings the growth in spending a bit closer to the historic average. So if you look back over time, the NHS generally gets between 3 and 4% spending growth in real terms every year. And that helps keep up with changes in the population, new technology. And it hasn't got that over the decade going into the pandemic. And that's one of the reasons why the health service is under strain. But the funding settlement was a short-term one. There was also a bit of a boost in spending on capital, buildings, equipment, IT, which was welcome. But really the big decisions on health spending haven't been made yet. They're going to be made in the summer for the rest of the Parliament. So the question is spending going to grow about that rate to enable the service to improve, not just stand still, or will it be constrained? And the economic context is challenging. So that's a decision not just about what government wants to put into the NHS. It's a decision about the balance of resources going into the NHS. And the other parts of the public sector, they're also under massive pressure. Social care services, public health services, the welfare bill, we've had cuts in welfare spending announced, which will harm health. So this is not just about the NHS. The environment is highly constrained. On your reform point too, yes, governments are going to want to have a narrative that reform's important, and of course it is, but you still need to have some ideas to guide that reform. And it's not clear at the moment, what are we, 9-10 months into the Labour government, what their guiding ideas are for how they want to use public policy to improve the health service. It's been a mixed bag. We've had some announcements that feel a bit like new public management, competition, league tables for hospitals, sacking managers that don't make the grade. We've got a health system actually that was recently reformed based on collaboration being the guiding principle. So it's hard to see actually when you stand back, what's the guiding ideas that are going to drive the health service over the next 5 years? What does this government think are the routes to improvement? Is it about equipping frontline leaders? Is it about new technology? Is it about slashing administration? It's not clear at the moment, and that does matter. So reform is important, but you need to have some ideas guiding it, and that needs to go with investment so you can direct it in the right places.
And I just wanted to go further on that and sort of see whether we can try and pull out some trends or some idea about what some of these guiding principles are. Because, obviously the government came in last summer, and Wes Streeting very quickly, made a deal with junior doctors, much more friendly on striking. We've had a real problem with unions and poor pay in the NHS, and there was a good agreement that was made. They moved very quickly on that. They straight away commissioned this Darcy report to kind of say everything before now is not our fault. This is the terrible way, and now this is a sort of fresh start. Good things, I think, in general. Then we've had this very sort of heavy top-down NHS England announcement. And we have some aspects which are sort of, like this recent announcement that hospitals are going to be paid to remove people from the waiting list. And, anybody that's actually worked in the NHS knows that there's going to be a lot of room for danger here. Like the NHS administration and the way that data is handled is really difficult and challenging. There are going to be a lot of people that are going to be removed because the incentive is the hospitals will get money, an unlimited amount of money, for how many patients they can remove from their waiting list because their treatment is no longer necessary. There's going to be huge room for mistake there. So what are some of the kind of ideas or trends that we're getting about how this government is approaching health? They've obviously made it a priority. They're this mission-led government. None of us know what these missions are. There's lots of chat about it. But what can we extrapolate from what's happened so far?
As you say, very quickly resolving industrial action, which was important, and changing the tone. And part of that was emphasizing the problems that were caused by the previous government, not them, and trying to work with staff. So that was important and good. But then we've had a set of measures that seem to be about pushing the system to work harder and trying to encourage competition. So league tables have been announced. We're going to probably have ratings for new bodies at a regional level. And so there's a bit of a new public management style targets and terror approach that seems to be part of the policy ideas. And that's got some similarities to the early 2000s, and some of the advisors that were working for Blair then are working for Streeting now. You've also got these ideas about, cross-government approaches to improving health. That's been largely rhetoric, less reality at the moment, I'd say. So they got elected on the idea that they were going to have this mission-led approach where health would run throughout government. And that means not just the NHS thinking about health, but also social security influencing health, housing influencing health. We haven't really seen what that means in practice yet. And then we have a set of ideas that are about what they want to do with the balance of resources in the health service. So they've talked about shifting care out of hospital, boosting prevention, and they talked about investing more in primary care as a proportion of resources to hospitals. So a nice set of ideas, but again, how that will happen in practice and how that matches up with the big political targets to reduce hospital waiting times is what we'll have to see over the next couple of years. So those seem to be the guiding ideas, but then you stand back and I think there's a political set of realities, which are money's constrained, access is poor, and there's going to be election in a few years' time. And so improving access is likely to be an overriding priority when people come back to the ballot box. And there's a question about whether they'll let Labour have the second half of their 10-year plan for the NHS. And so the reality is government does need to focus on tackling hospital waiting lists, making it easier for people to see their GP, some of the basics of delivering a high quality health service. And so these bigger ideas about reform are likely to be longer term ones. And the reality is likely to be drawn to these shorter term challenges about improving access. And that might be why these measures like financial incentives on the waiting list, targets for reducing the waiting list with strong top-down political management of them, are likely to be a feature of the next couple of years, whatever government says about shifting to prevention and joining up with other departments over the long run to improve health. Good ideas, but they're faced up with a big reality, which is long waiting lists and poor access now.
The Health Foundation, I know, is, been thinking a lot about AI and health tech in the NHS. I've been struggling recently to really think about what the benefits are that we've seen over the last 15 years. Obviously, there's an enormous potential here, and it's something that the NHS must embrace. But when I look back to, say, 2010, when I was a junior doctor and all of the hype around how AI and health tech was going to completely revolutionize things, and there was the Topple review and how we all needed to be retrained, I don't see any of that really in any transformational sense. What's your thoughts? What's going on?
My take is that we need to shift the way we're thinking about AI and the health service. At the moment, it seems to be this expectation that there's this amazing whizzy stuff happening somewhere that at some point we can receive, adopt, and it's going to transform the way we work. It's quite passive. It's quite based on the market coming up with cool stuff that will just work and we can implement. I think we need to flip that around and say, how does government, the state, the NHS shape the development of new technology so it benefits the health system and meets the very real practical challenges that we face right now? So a good example is there are some examples of these technologies which could free up clinicians' time to be able to provide more direct care. And those are based on technologies that already exist. For instance, in general practice, it seems to be there's some technologies that could do some administration tasks that could free up GPs' time. Well, fantastic. So what do we do to invest in those technologies, test them to see if they really work, spread them across the NHS? And that requires being much more active in having a strategy for how AI will be used in the health system, not just letting it come. So the idea that government's got this shift, we're going to shift to use, towards using digital technologies. I think we need to actively steer to make sure that these things do benefit the NHS and they don't focus on the worried well rather than the people that have complex conditions, that they don't exacerbate inequalities, which we already know are deep. The problem, I think, is at the moment, the development of these technologies is rapid and we haven't caught up with how we want to govern them and steer them for public benefit.
I totally agree with you. And I think there are some good examples in the US, aren't there, where, there's a sort of health tech and AI is built into the system and generated from that system and is context specific and built for a particular local application. And, there are other examples in Singapore, in China, Hong Kong. But we don't seem to have any interest in trying to build the kind of internal expertise that would facilitate that. So in the absence of that, and in the absence of us probably being able to, really think about shaping AI and health tech from its development, but kind of trying to buy in expertise or buy in programs, how do we best utilize it? How can we make it work? Do you know what I mean? Because it seems like such a shift that we would have to go under to have that type of internal expertise where we're generating these programs, we're generating this technology, we're implementing it in a context-specific kind of way. What's the sort of middle path?
Yeah, well, and there's pockets of good examples in different parts of the country where innovative leaders grip the stuff, or there's an idea that's come up in a local trust, or like in London, they're interested in some of these new technologies. So the task is to take it from pockets where there's interest and there's expertise and to make it more systematic, and also to use the benefits of a single payer system to be able to identify potentially totemic innovations that could help support the implementation with the scarce management resource we have. The NHS is undermanaged, not overmanaged, and we're cutting management further. To evaluate rapidly in a real world setting and then to see if the stuff is nonsense or it's going to help. And some of it is nonsense and some of it will help. So I think it's about becoming far more national in our approach to thinking about this work and supporting the local examples. But it links to another part of the government's agenda, which has been stripping back management costs. So as well as scrapping NHS England and merging it into the department and cutting their staff, we have regional entities called integrated care boards, lots of jargon in the NHS, but they're basically regional planning groups. And they're also likely to see their management costs cut in half. So who's going to be doing the planning? Who's going to be doing the support for implementation for new tech? New tech isn't just a thing. It's a human, social, messy process that requires people to support it, to understand whether it works, to work with clinicians. So I worry that we're cutting back on, in the attempt to reduce deficits in the short term, we're cutting back on the scarce management resource we have when we really need to be boosting it. Making change happen is very, very complex, very hard. The NHS has not always been good at it. So cutting back on the managers we do have at a local level is only going to make that harder.
Well, I wanted to ask a very difficult question, Hugh, which is I don't think we could talk about this whole topic without talking about social care. The last few governments have all gone, yes, we're going to do something about social care, and then kind of like just at the last minute gone, you know what, this is going to be very difficult. We'll do something about social care at some point in the future. What have Labour said so far about reforming social care? And what are your opinions on what needs to happen with the system?
So basically, it's the same pattern so far, unfortunately. So Labour came into government with a manifesto that said they wanted to have a national care service, vague on what that meant, but implicit in a much more comprehensive national approach to delivering social care services. Right now, the system is a threadbare safety net with publicly funded care only available to people with the highest needs and the lowest means. Lots of people fall through the gaps. There's a high reliance on unpaid carers. The system is broken and it needs fixing. As you say, successive governments have promised to reform the system over decades, then ducked it. And so far, what we've seen from this government is they came in actually inheriting some quite limited but important reforms to the social care system that were introduced under the last government. To introduce a cap on an individual's lifetime care costs at the moment, those could escalate and be catastrophic. They rode back on that cap, so that will now not be implemented. So they've gone backwards on some reform. And then they've set up, déjà vu, an independent commission to look at policy proposals for improving the system. That's going to have an interim report in not too long, a year and a bit, and then a final report in about 3 years, I think, conveniently after the spending review period. And just going into an election. Now, the health secretary said that social care plans and elections are not a good combination, and he's right. The problem is they're likely to go into an election just having formed a plan for social care reform. So I really hope that I'm wrong about this. It's easy to be skeptical, and the glass half full version is they've set up an independent review because they really want to change the system and they want to get expert views. And maybe it will report much sooner and maybe reform will happen. But we've been here many, many times before. We've had a long line of independent reviews, commissions, proposals. There's not that many new ideas on the reform needed in social care. The problems are well known. The solutions are well known. The missing ingredients have been political will and investment. And so those are the things we need, less, more ideas. But hopefully this review, Louise Casey is running it. She's tackled some complex public policy problems in the past. Hopefully this will help catalyze the change we need. But history suggests we should not be optimistic.
Yes, I think governments have been spooked, haven't they? Especially since Theresa May's sudden reveal of a care reform policy during the election campaign, which essentially kind of upended her entire campaign, didn't it?
And Burnham faced the same challenges too. So there's a long line of these debates. The problem is the public don't really understand the social care system. Many people expect it's going to be free and available to them like the NHS. And so mobilizing public support for change is also challenging when understanding of the system is low. But the arguments for reform are convincing. We have a system now where, as I say, it's a threadbare safety net. We need risk pooling across the population where people who need care get it, where resources are available and they're not having to rely on friends, families, or their life savings. We don't really have a national system at the moment, and we need to move to something far more comprehensive. We also have a problem in the social care workforce where many care workers live in poverty. Pay is low. So there's a bunch of different problems that need to be addressed, but they are well known and solutions to them have been implemented in other countries. The question is, do politicians want to do it, and are they willing to invest in improving the system?
The public's biggest complaint quite a lot of the time is the difficulty of getting a GP appointment. So what changed on that in the 2010s under the Conservative government, and what's Labour said about addressing it and so far since they took over?
We run public polling every 6 months with a representative sample of the public, and for the first time recently, access to general practice is their priority for improving the health system. It's a complex picture when you look at access, but national surveys seem to suggest over time people have found it harder over the last decade to get through to their GP practice on the phone and get an appointment when they want to. They've also found it harder to see their named doctor if they have one, or the doctor they want over time. So you've got a problem of declining access or experience of access, and declining continuity of care, which we know is really important, particularly for people with long-term conditions. So what's happened over that period? Well, investment has stalled over the 2010s and before Labour came into power. It's also been slowing, and then actually a decline in full-time equivalent GPs working over that period. There's been an uptick recently because of the boost in training. So activity's gone up, GP numbers haven't. And there's been this mismatch between appointments and the number of GPs available to deliver them. But also access is not just about supply and demand. Patients have problems with booking systems, complex routes to access general practice, not always knowing who they're going to see, increased complexity and just trying to get an appointment. So that's the problems. In terms of the solutions, what we've heard so far have been that this government wants to shift the balance of resources towards primary care in the community. So an expectation for increased investment. It said it wants to bring back the family doctor. So presumably that means trying to enhance continuity of care. And it's stripped back some of the targets for GPs. There's a long list of things they can get extra additional payments for to try to simplify the system. But we still don't know exactly what they want to do to reform primary care. And that's going to be one of the big things to look out for in the 10-year plan. And really, primary care is the jewel in the crown of the NHS, this sort of comprehensive system that can treat people and their families from cradle to grave. So the big question is, will that system have the resources and be supported to evolve, adapt with new technology, to more closely integrate with other services in the community? Or will government try and do something radically different? That would probably not be wise. We've got a model that can work if supported, but we'll wait and see in the 10-year plan for what government wants to do.
A good way to finish up would be to ask you, if you were a betting man, what would you think was going to be in the 10-year plan?
I think in the 10-year plan, probably the big set of changes will be, how do you support this shift towards more services being delivered out of hospital, in primary care, in the community? That's not a new idea. It's not a new set of challenges, but it's something that the NHS has struggled to do, to sort of match the policy rhetoric of doing this with the reality of the system changing. So I expect the big proposals in the plan to be around how government's going to encourage, for instance, GPs to work more closely with mental health services, social workers, for a broader range of services to be delivered outside of hospital. I think that's going to be the big set of changes. There's likely to also be there's got to be something about what the NHS is going to do to identify promising technological innovations and integrate them into how it works. But I think the big game in town is primary and community services and how they can be supported.
That's a good place to finish, and it kind of ties together a lot of what we've talked about on this podcast. So Hugh Alderwick of the Health Foundation, thank you so much for joining us on the podcast.
Thanks so much.
Thanks so much for listening to this episode of the Lancet Voice. Please subscribe and leave us a review if you haven't already, and we look forward to seeing you again next time here on the Lancet Voice.